Hi, my name is Kiera Nabi, and this is my recording for the Unit 4 Case Connections video. Beginning with case number 1. In this case, a newborn female seems healthy at birth. However, within 24 hours, the newborn develops the following symptoms: lethargy, hypothermia, and apnea. Based on these symptoms, medical professionals suggest she may have an oxidation disorder or a urea cycle disorder. The best diagnostic tool to distinguish between a beta oxidation disorder and a urea cycle disorder is to evaluate the levels of her plasma glutamine. If a urea cycle disorder is suspected, medical professionals should evaluate ammonia and glutamine levels immediately. Almost always, elevated glutamine levels are accompanied with elevated ammonia levels, indicating a urea cycle defect. Glutamine level abnormalities are very rarely reported in oxidation disorders. Based on the results of this test, medical professionals can begin treatment for a urea cycle disorder or order secondary tests, including serum fatty acids or urinary acid evaluations. Slightly abnormal urinary acids typically indicate beta oxidation disorders. However, urea cycle disorders are associated with significant abnormalities in urinary acids. In each scenario, further testing will need to be conducted to confirm either case because both disorders produce urinary acid abnormalities. An evaluation of serum fatty acids is most likely ordered when primary tests indicate the presence of beta oxidation disorders. The analysis of acyl carnitine and free carnitine levels is used as a secondary test. A blood glucose test simply provides the amount of glucose in blood circulation and can indicate hyperglycemia or hypoglycemia. This test is mainly used in diabetic patients to monitor their glucose levels, and therefore would not be the best diagnostic tool to differentiate between metabolic defects. Both defects, beta oxidation and urea cycle defects, can be definitively identified through genetic testing. According to the newborn's blood work, with elevated orotic acid and ammonia levels, she is most likely experiencing the symptoms of an ornithine transcarbamylase, or OTC, deficiency. An OTC deficiency causes carbamoyl phosphate to accumulate within the liver's mitochondria because the enzyme cannot condense the substrate with ornithine to produce citrulline. Eventually, the additional carbamoyl phosphate passes through the mitochondrial membranes into the cytosol, where it attempts to enter the pyrimidine pathway. This diffusion into the cytosol and entry into the pyrimidine pathway causes a spike in orotic acid production and secretion. The urinary orotic acid results indicate the carbamoyl phosphate synthetase 1 enzyme is properly functioning. Urinary orotic acid tests can be used to differentiate defects in ornithine transcarbamylase and carbamoyl phosphate synthetase 1. As shown in this example, elevated levels in orotic acid indicate ornithine transcarbamylase defects. On the other hand, normal or slightly low levels unveil carbamoyl phosphate synthetase 1 defects. Based on her symptoms and the test results, This newborn female is suffering from the effects of a complete ornithine transcarbamylase deficiency in the urea cycle. Apnea, lethargy, and hypothermia are typical indications of a urea cycle disorder. Based on the results of her tests, medical professionals are able to identify the enzyme in which she is deficient, ornithine transcarbamylase, causing her orotic acid and ammonia levels to be remarkably elevated. This disorder is the only X-linked defect in the urea cycle, promoting it to be more prevalent in male patients. The newborn will need infusions of sodium phenylacetate and sodium benzoate for alternative pathways of nitrogen excretion. Moving on to Case 2. Case 2 presents two infants, Patient A and Patient B, that seem to be experiencing complications from phenylketonuria. In a neonatal blood panel, both patients revealed elevated levels of phenylalanine. Elevated phenylalanine levels can be a result of a mutated gene causing a lifelong disorder, or consumption of high-protein foods such as eggs and meat. Phenylketonuria can be definitively diagnosed through genetic testing. If phenylketonuria is diagnosed, the amino acid tyrosine may become essential in the diets of these individuals. This autosomal recessive disorder is caused by a genetic mutation in the gene that codes for phenylalanine hydroxylase in the liver. Phenylalanine hydroxylase, with the aid of tetrahydrobiopterin as a cofactor, is responsible for converting phenylalanine to tyrosine. Tyrosine is needed in the body to create neurotransmitters such as epinephrine. A BH4 loading test is conducted on individuals suspected of exhibiting the mutated gene to test the responsiveness of the pathway. The BH4 loading test evaluates the phenylalanine levels in the blood over the course of 8 to 24 hours, depending on which test is ordered by a medical professional. Responsive phenylketonuria will be exposed if a decrease in phenylalanine levels are seen. Unfortunately, not all patients are responsive to BH4, indicated by little change or continually elevated changes in the phenylalanine levels. As shown in the figure, patient B has a positive result for responsive phenylketonuria. Prognosis for this patient is good. Management of this disorder includes medications and a formulated diet. In this patient's infant years, he or she can consume breast milk with the addition of lopinalac, a special formula, to the regular diet. As the patient begins to consume solid nutrients, he or she needs to avoid high-protein foods. A special phenylketonuria formula will need to be essential in the diet for the entirety of the patient's life. As for patient A, the results denote an unresponsiveness to the BH4. This can signify that a longer test may need to be performed for phenylketonuria, or the patient has a tetrahydrobiopterin deficiency. Dihydropteridine reductase deficiency is known to show these results following a BH4 load. This deficiency is known to cause defects in BH4 regeneration. A test measuring pterin metabolite levels will need to be conducted for final diagnosis, indicated by extremely elevated biopterin with normal neopterin levels.